Lesson 5. Pharmacotherapy as the foundation of treating depression. Beginning the treatment of depression with pharmacotherapy is neither a worldview choice nor a concession to medical pressure. It is a decision grounded in responsibility for the patient's life and health. In its clinical dimension, depression is not merely a state of low mood or an emotional crisis that can be thought through. It is a disorder in which the fundamental mechanisms of biological regulation cease to function in a predictable and safe way. This is a fact. At the same time, depression is remarkably effective at masking its own danger. Patients often retain the capacity for logical thinking. They can argue, plan, and convince those around them that they are in control. Meanwhile, at the biological level, the systems responsible for risk assessment, impulse inhibition, and emotional regulation become dysregulated. In such a state, the subjective sense of control can be an illusion, and decisions made by the patient may be radically inadequate to the real level of threat. Depression is a state of biological risk also because its course can be dynamic and unpredictable. Suicidal thoughts do not always appear at moments of greatest suffering. They often intensify when tension begins to ease slightly and the patient regains a minimal capacity for action. This is one of the most dangerous phases of the illness, because it combines a subjective sense of relief with a still distorted assessment of consequences. For this reason, pharmacotherapy serves a protective function in the treatment of depression. Its primary task is not to improve quality of life or restore a sense of meaning, but to reduce risk. Medications stabilize the nervous system enough for impulsivity and extreme emotional reactions to stop dominating behavior. They create the conditions in which further treatment becomes possible. They do not replace it. At this point, it must be stated clearly, a patient in a state of severe or moderate depression is not a fully reliable judge of their own safety. Not because they do not want to live, but because their nervous system does not provide stable feedback. Depression distorts temporal perspective, warps the evaluation of the future, and dramatically narrows the field of vision. What is temporary feels permanent. What is reversible appears final. In this sense, pharmacotherapy is not a shortcut in treatment, but a safeguard against the most serious consequences of the illness. It does not mean giving up on personal work or surrendering to life problems. It means acknowledging the fact that, at a certain point, biology must be stabilized before it is safe to work at the level of psyche and behavior. Only on such a foundation does further treatment become possible for psychotherapy, nervous system regulation, and meaningful, well-matched activation. Without this foundation, each of these methods risks becoming ineffective or even harmful. That is why pharmacotherapy does not occupy a privileged ideological position in this model, but the first position out of necessity. 1. Pharmaceuticals in the treatment of depression, safety tools, not promises of happiness. Medications used in the treatment of depression do not form a homogeneous group and do not serve a single function. Their common denominator is not mood improvement in the everyday sense, but biological stabilization in situations where the body's natural regulatory mechanisms fail. From the perspective of treating depression, pharmaceuticals should be understood not as agents of feeling good, but as tools that reduce risk and make further therapy possible. Sleep is also a frequent topic in the treatment of depression. Hypnotic medications can be necessary when insomnia becomes a factor that perpetuates the illness. Their role, however, is strictly limited. Pharmacologically induced sleep does not replace circadian rhythm regulation and does not rebuild natural mechanisms of recovery. Overuse of sleep medications leads to tolerance, dependence, and worsening sleep problems after discontinuation. In this sense, they are an intervention tool, not a long-term solution. In some patients, especially those with severe, recurrent, or atypical depression, mood stabilizers and adjunctive medications are used. Their task is not to elevate mood, but to limit intense emotional fluctuations, impulsivity, and destabilization. Similarly, antipsychotic medications, sometimes used in severe depression with psychotic features, are not evidence of a diagnostic mistake, but an attempt to protect the patient from losing contact with reality. Their presence in depression treatment often provokes fear and resistance, yet in specific situations they serve a protective rather than stigmatizing role. A particular danger in pharmacotherapy is goal-less polypharmacy. Combining multiple medications can lead to a state in which the patient no longer suffers, but also no longer truly functions. A phenomenon of pharmacological removal from reality appears. Emotions are flattened, reactions blunted, and the capacity for change diminishes. Such a state is sometimes mistaken for stabilization, when in fact it represents nothing more than chemically maintaining the patient in suspension. For this reason, a proper understanding of the role of medications is essential. Pharmacotherapy in depression is meant to enable treatment, not replace it. It should reduce suffering and risk to a threshold at which psychotherapy, nervous system regulation, and meaningful activation become possible. Medications are the foundation because, without them, it is often impossible to begin therapy safely. At the same time, they remain a transitional tool which, without further work, leads either to relapse or to pharmacological dependence. Understanding this distinction is one of the most important moments in treating depression. A patient who knows why they are taking medication and what they should not expect from it is far less likely to fall into the trap of false improvement or chemically substituting life itself. Only on such ground does pharmacotherapy cease to be a threat and begin to fulfill its proper role, the role of a foundation upon which the further process of treatment can be built. 2. Antidepressant medications, the core of pharmacotherapy in depression. Proper antidepressant medications constitute the foundation of pharmacological treatment for depression. Their action does not consist in improving mood in the subjective sense of feeling happy, but in long-term modulation of neurotransmitter systems responsible for emotional regulation, stress response, and adaptive mechanisms. In clinical practice, this translates into a gradual reduction in vulnerability to extreme emotional states, rumination, and impulsivity. The most commonly used group are selective serotonin reuptake inhibitors, SSRIs. Their mechanism involves inhibition of the serotonin transporter, SERT, which increases the availability of this neurotransmitter in the synaptic cleft. This group includes, among others, fluoxetine, sertraline, citalopram and escitalopram, paroxetine, and fluvoxamine. These medications have a relatively favorable safety profile but require time, and meaningful therapeutic effects usually appear only after several weeks of regular use. Another widely used group are serotonin norepinephrine reuptake inhibitors, SNRIs. They act on both serotonin and norepinephrine transporters, exerting a stronger effect on the regulation of energy, concentration, and stress responses. This group includes venlafaxine, duloxetine, and desvenlafaxine. These medications are often particularly useful in depressions characterized by pronounced psychomotor slowing, somatic symptoms, and chronic tension. In clinical practice, older classes of antidepressants are still used as well, such as tricyclic antidepressants, TCAs, including amitriptyline, imipramine, and clomipramine. Their action involves multiple receptor systems simultaneously, which makes them effective but also associated with a higher risk of adverse effects. For this reason, they are currently used mainly in treatment-resistant cases or for specific clinical indications. A separate category consists of medications with atypical mechanisms of action, such as bupropion, a dopamine and norepinephrine reuptake inhibitor, or mirtazapine, which acts through modulation of adrenergic and serotonergic receptors while also influencing sleep and appetite. These medications are often employed when classical SSRIs are poorly tolerated or fail to produce the expected effect. An important aspect of depression pharmacotherapy is that the mechanism of action of antidepressants cannot be reduced to simply raising serotonin levels. Contemporary psychiatry increasingly emphasizes the role of receptor adaptation, neuroplasticity, and effects on neural networks responsible for emotional regulation. This explains both the delayed onset of action and the fact that clinical improvement does not always directly correlate with a subjective sense of better mood. It is also crucial to recognize that the response to antidepressant medications is individual. The same drug may bring significant improvement in one patient and be ineffective or poorly tolerated in another. For this reason, pharmacotherapy is not about finding the best medication, but about a process of careful adjustment conducted by a psychiatrist, taking into account symptoms, medical history, and the body's response. 3. Anxiolytic and sedative medications, rapid relief, high risk. Anxiolytic and sedative medications occupy a special and simultaneously dangerous place in the treatment of depression. They provide fast, clearly perceptible relief from tension, anxiety, and agitation, which makes them attractive both to patients and to healthcare systems. The problem is that speed of action is not equivalent to therapeutic effectiveness, and in the long term it can become a source of serious harm. The most important group of anxiolytic medications are benzodiazepines. Chemically, these are benzodiazepine derivatives that act as positive allosteric modulators of the GABA-A receptor. In practice, this means enhancing the inhibitory effect of gamma-aminobutyric acid, GABA, the main inhibitory neurotransmitter in the central nervous system. The result is a rapid reduction in anxiety, muscle tension, and psychomotor agitation. This group includes, among others, diazepam, lorazepam, alprazolam, clonazepam, bromazepam, and oxapam. They differ in potency, half-life, and clinical profile, but share a common mechanism and a common risk. Benzodiazepines do not treat depression. They temporarily cover it up by suppressing anxiety and tension symptoms that often accompany the illness. The most serious danger associated with this group of medications is their high potential for dependence, both physical and psychological. The nervous system rapidly adapts to their presence, leading to tolerance. Over time, the same dose becomes ineffective, and attempts to reduce it trigger intensified anxiety, insomnia, irritability, and withdrawal symptoms, which patients often interpret as a return of the illness. In this way, the medication begins to function as a regulator of everyday functioning rather than as therapeutic support. The history of benzodiazepines represents one of the most important warnings in modern psychiatry. Diazepam, Valium, was widely promoted in the 1960s and 1970s as a remedy for tension, frustration, and the difficulties of everyday life. Advertised as safe and almost risk-free, it led to waves of dependence and pharmacological withdrawal across entire social groups. The experience of the United States demonstrates that long-term treatment of anxiety and depression with sedatives leads not to recovery, but to chronic dependence. In the treatment of depression, benzodiazepines may have limited, short-term use, for example, in acute anxiety states, severe insomnia, or in the initial phase of antidepressant treatment before primary medications take effect. The condition for their use, however, must be a clearly defined goal and time frame, not an open-ended, taking them because they help. Alongside benzodiazepines, other sedative and anxiolytic medications are also used, such as hydroxin, a piperazine derivative and H1 histamine receptor antagonist, or certain antidepressants with sedating properties. Although they do not carry the same high risk of dependence as benzodiazepines, their function remains similar: symptom relief rather than treatment of the underlying cause of depression. Particularly dangerous is confusing sedation with improvement. A patient may appear calmer while simultaneously experiencing emotional flattening, reduced reactivity, and loss of capacity for genuine therapeutic work. A state of pharmacological anesthesia emerges, socially acceptable, yet therapeutically sterile. In such a state, psychotherapy loses its meaning, and activation becomes either impossible or artificial. For these reasons, anxiolytic and sedative medications cannot be the pillar of depression treatment. They may serve an auxiliary, interventional, or transitional role, but their long-term use without parallel therapy leads to consolidation of the illness in a new, pharmacological form. Their proper place is clearly defined: short-term safety support, never a substitute for treatment. For hypnotic medications, support for sleep or a chemical prosthesis of recovery. Sleep is one of the most important regulators of the course of depression, and sleep disturbances are among the strongest factors maintaining the illness. For this reason, hypnotic medications are sometimes introduced as an interventional tool. Their role, however, is strictly limited and easily subject to misuse. Pharmacologically, both classic sleeping pills and sedative agents are used, including certain antidepressants and so-called Z drugs, e.g., zolpidem, zopiclone, which act via the GABA-A receptor. Their common goal is to facilitate falling asleep or to prolong sleep, not to restore the natural circadian rhythm. The problem is that pharmacologically induced sleep is not equivalent to physiologically restorative sleep. Hypnotics do not teach the body how to sleep, they chemically replace the process. With prolonged use, this leads to tolerance, deterioration of sleep quality after discontinuation, and psychological dependence on the medication as a prerequisite for falling asleep. In the treatment of depression, sleeping pills may make sense in the short term, when insomnia is extreme and prevents any stabilization. They cannot, however, constitute a long-term strategy. Without parallel work on circadian rhythm regulation, stress reduction, and nervous system regulation, they become another pharmacological prosthesis, masking the problem rather than solving it. Their proper place in therapy is auxiliary and temporary. Sleep should return as a biological function, not as the effect of a pill. Without this, depression treatment remains incomplete, even if the patient sleeps better. 5. Mood stabilizers and antipsychotic medications when depression is not pure. Not every depression follows a uniform and predictable course. In some patients, marked emotional instability, impulsivity, abrupt mood swings, or episodes unresponsive to classic antidepressants are observed. In such cases, mood stabilizers and, in selected situations, antipsychotic medications are introduced, not as first-line treatments, but as tools to secure the therapeutic process. Mood stabilizers aim to smooth extreme emotional fluctuations, reduce impulsivity, and prevent sudden shifts between states of activation and low mood. This group includes, among others, lithium salts, valproates, valproic acid, carbamazepine, and lamotrigine. Their effect does not consist in improving mood in a subjective sense, but in increasing the stability of emotional responses and reducing the risk of abrupt decompensations. They are particularly important in recurrent depressions, treatment-resistant cases, and situations where the clinical picture suggests an effective component extending beyond a classic depression. The introduction of a mood stabilizer often indicates that the problem is not merely low mood, but instability of the emotional regulation system. In such states, antidepressants alone may exacerbate fluctuations or prove insufficient. Emotional stabilization then becomes a prerequisite for the safety of further treatment, including psychotherapy and activation. Antipsychotic medications used in depression play an auxiliary and protective role. They are not evidence of a misdiagnosis, nor are they synonymous with a diagnosis of schizophrenia. They are employed in severe depressions with psychotic features, derealization, intensified delusional thinking, or extreme disorganization of thought. Most often, these are atypical antipsychotics used at low doses, aimed at limiting loss of contact with reality rather than treating psychosis as such. In both cases, mood stabilizers and antipsychotics, the proper positioning of their role is crucial. These are not antidepressants in the colloquial sense, but tools used when the course of the illness requires additional biological safeguarding. Their task is to enable further treatment, not to replace the therapeutic process. Understanding this distinction helps avoid both unnecessary fear and false expectations. The more complex the course of depression, the greater the importance of precise diagnosis and the conscious use of pharmacological tools, always as a foundation, never as the entirety of treatment. 6. Self-administration of medication and side effects, an area of real risk. Pharmacotherapy for depression is an area in which patient self-reliance is not an advantage but a potential danger. Psychotropic drugs are neither supplements nor ad hoc remedies. Their dosing, combinations, and changes in treatment regimens must be conducted under the strict supervision of a psychiatrist, because they directly interfere with the functioning of the central nervous system. One of the most serious mistakes is independently increasing or decreasing doses by feel. A patient who feels worse may conclude that the medication is not working and increase the dose. A patient who feels better may decide that the medication is no longer needed and stop taking it. Both behaviors are dangerous. Sudden dose changes can lead to symptom exacerbation, withdrawal syndromes, emotional destabilization, and in extreme cases a rapid deterioration of mental state. Self-combining medications is particularly risky. Patients often take, at the same time, drugs previously prescribed, medications from other physicians, sleeping pills, anxiolytics, or substances to calm down, without informing their psychiatrist of the full treatment regimen. Such mixing can lead to pharmacological interactions, excessive suppression of the nervous system, disturbances of consciousness, and a false assessment of treatment effectiveness. It is the physician, not the patient, who sees the whole system and its potential consequences. Every group of medications used in depression is also associated with possible side effects, which are not signs of poisoning but the result of interference with complex biological systems. Antidepressants may cause transient increases in anxiety, sleep disturbances, gastrointestinal complaints, changes in appetite, decreased libido, or a sense of emotional blunting. Anxiolytics and hypnotics carry risks of drowsiness, impaired concentration, tolerance, and dependence. Mood stabilizers and antipsychotic medications require regular monitoring, as they may affect metabolism, body weight, electrolyte balance, or other somatic parameters. Crucially, side effects should not be evaluated in isolation. A symptom that is troublesome at the beginning of treatment may subside over time. A symptom that seems harmless may require treatment adjustment. Independent interpretation of these reactions very often leads to hasty decisions that destabilize the entire therapeutic process. The appropriate response to adverse effects is not stopping the medication, but contacting the physician and jointly modifying the regimen. For this reason, depression pharmacotherapy requires a relationship based on trust and cooperation. The patient does not need to know detailed chemical mechanisms, but must understand one thing: psychotropic medications are not an area for experimentation. Any dose change, any new drug, and any combination of substances should occur consciously, deliberately, and under specialist supervision. This warning is not meant to instill fear of treatment. Its purpose is to clearly define the boundary of responsibility. Pharmacotherapy can be a safe and effective foundation of depression treatment only when it remains treatment, not a self-managed means of emotional regulation. Summary: pharmacotherapy in the treatment of depression is neither a solution to all problems nor a worldview choice. It is a necessary foundation of safety, without which further treatment often cannot begin. Its primary role is to reduce biological risk, lower impulsivity, and stabilize the nervous system to a level that allows reflection, therapy, and action. Proper antidepressants form the core of this treatment stage. They work slowly, do not improve mood immediately, and do not produce happiness. Their task is to modulate regulatory mechanisms, not to replace life itself. Anxiolytic and sedative drugs may provide rapid relief, but carry a high risk of dependence and pharmacological withdrawal from reality. Therefore, their place is exclusively short-term and auxiliary. Hypnotics may support sleep in acute phases of illness, but they do not replace natural regeneration. Mood stabilizers and antipsychotic medications are used when the course of depression is unstable or severe and requires additional biological safeguarding. A common mistake is treating pharmacotherapy as a standalone treatment strategy. Medications do not solve life problems, rebuild relationships, or teach emotional regulation. Their proper function is to create conditions in which psychotherapy, nervous system regulation, and meaningful activation become possible. Used without this context, they lead either to relapse or to lasting pharmacological dependence. Pharmacotherapy works effectively only when it is planned from the outset as a stage of the process, not its goal. Only on such a foundation can one move to the next pillar of treatment, the regulation and calming of the overloaded mind, which is the subject of the next lesson.